Kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit. And it's my great pleasure tonight to welcome Ryan Paul back. So Paul is an endocrinologist at Te Whatu Ora in Waikato, associate professor at the University of Waikato, and an honorary staff member at the University of Auckland, with a great passion for teaching diabetes, which is absolutely amazing. It's been supported by Boehringer Ingelheim and Lilly, but the educational component has been developed by the Goodfellow Unit and Ryan Paul. So Ryan, over to you, sir.
Kia ora, Bruce, and kia ora koutou. No mai haere mai to this webinar on what can be a very complex and daunting time, but hopefully I'm going to try and break it down and simplify it as much as possible. We all know that diabetes is a major cause of premature death in Aotearoa, and it creates some of the greatest inequities in health. And that 2/3 of people with diabetes will die from cardiovascular disease. It's also really important to know that the other third will also primarily die from diabetic complications, including renal disease and cancer. And diabetes will affect virtually every system in the body. And just through default, hand in hand, it goes with many other conditions, particularly those of metabolic syndrome. And we think about our sleep apnea, our polycystic ovarian syndrome, gout, and all the many others that go with it. You'll all be very familiar with the complications of diabetes. I've listed them all there. It's not just the vascular ones that we think of. We're very familiar, with eye disease, kidney disease, neuropathy, cardiovascular disease, peripheral vascular disease, but also want you to think about the other ones that sometimes we forget about, which can often have a really important impact on quality of life. We're also thinking about, dental periodontal disease. It's the GI disease components. It's the mental health and the musculoskeletal, frozen shoulder. It's the cancers. So when we think about someone with diabetes, sometimes they are very complex and it's all encompassing. It takes a holistic approach to the patient and to the whānau. So I really wanted to go through, I don't mean this in a condescending way, but how can we simplify what we're trying to achieve in management? Like number one, we've got increasing life expectancy, and a lot of that is really around trying to prevent and delay the progression of cardiovascular disease and renal disease. We've obviously got improving quality of life, and for many whānau, that could be more important than increasing life expectancy. But not only how can we prevent diabetic complications from happening, but once they're there, how can we delay and slow them, and also treat them to keep our whānau well with diabetes. At the same time, we're trying to do that. We're also trying to balance it up with minimizing, first do no harm, minimizing those adverse effects. And how can we actually limit the number of medications in a time where it seems to be we're prescribing more and more often? So when we go through, and it will be a case-based journey that we travel through managing diabetes and its complication, I want you to try and think at each stage, what is the best management that I can do to achieve the goals that I want to? See, our first case was Mr. W, and he's probably someone who's very common in your practice. He's a 61-year-old Māori man, long-standing history of type 2 diabetes, and he's got multiple comorbidities, which I've listed there, including vision-threatening eye disease. He's already on 6 weekly Avastin injections. He has renal impairment with the EGFR of 36 ml per minute and macroalbuminuria. He's got heart failure going along with that. He's had a previous MI. He's now got AF with his heart failure. He's also got gout and peripheral vascular disease, including losing a toe. And he's got all those cardiovascular risk factors with hypertension and dyslipidemia. And he's also got sleep apnea on CPAP with a current BMI of 35. So with that, you're doing well in treatment. And this is the medication regimen that he's on. This is also not atypical, but you've got him on maximum dose Galvimet with some glycoside and Lantus for his glycemic control. He's on perindopril, felodipine, doxazin in terms of blood pressure. He's on some frusemide, metoprolol, allopurinol for gout, simvastatin, and he is intolerant of higher doses with that current LDL 3.5 and aspirin as well. So his first question of the night is, his current HbA1c is 58 millimole per mole. Should his glucose-lowering therapies be increased? And if so, how? And I really want you, as we go along this case, think about what you'd do in the exact situation. Well, the first thing I'm going to say is first do no harm. And remember that for all people with diabetes, that we need to reduce the doses of our glucose-lowering therapies as renal function declines. Now, and I've just broken them down there for each specific medication. Now, the MedSafe data sheet will say that the dose of metformin needs to be reduced once eGFR is less than 60. But now all international guidelines, and we're including New Zealand's, and we're updating the New Zealand formula as well. We only need to reduce the dose of metformin once the eGFR is less than 45 ml per minute, and that's a maximum of a gram a day. And the stepwise reduction there, we need to stop it once the eGFR is less than 15. So with vildagliptin is safe to use in end-stage renal failure, but you do need to reduce the dose to 50 milligrams once a day, once the eGFR is less than 50. For Jardiance or empagliflozin, now this is another one that can catch people out. The MedSafe data sheet says do not use once the eGFR is less than 30, but once again, our guidelines in Aotearoa and international guidelines now recommend only not starting empagliflozin once the eGFR is below 20. So if the eGFR is above 20, you can start Jardiance anytime, and you do not need to stop it unless they have adverse effects or start dialysis. And I'll go through that in a couple of slides as well. Our GLP-1 receptor agonists, dulaglutide or Trulicity, and liraglutide Victoza, you do stop those once the eGFR is less than 15. And you don't use the other agents there in end-stage renal failure. So in end-stage renal disease, the only medications that you can use in terms of glucose lowering are vildagliptin or insulin. And just be aware that you often need to reduce the dose of insulin as renal function declines. That's multifactorial. That's one, because insulin's renally cleared. It's also because you have lower capacity to fight hypoglycemia because you've lost gluconeogenesis in the kidneys. So that's first of all in terms of that first do no harm with declining renal function. And the next big point, which really is a take-home message, is that all your people with diabetes that have cardiovascular disease, renal disease, or heart failure should ideally be on Jardiance or Trulicity or Victoza, unless there are any contraindications. And the big reasons why is they're all potent agents in secondary prevention of cardiovascular disease and aid with weight loss. And Jardiance is also effective in reducing the progression and death from renal disease and heart failure. And in our patients with multiple comorbidities, empagliflozin is also effective at lowering uric acid levels. It's been found to reduce medications for gout as well, although there's no hard outcomes in terms of reducing exacerbations of gout. But to be fair, there'd be no decent RCTs for that. So that we may push you in one direction or the other. And coming up later in the talk, I will talk about, because it can be quite difficult to decide, should my patient be on Jardiance? Should they be on Trulicity or Victoza? Because we're kind of forced into that decision by Pharmac. But there are a number of factors to consider, which I will go through. Another take-home message about Jardiance is that basically the more the renal impairment, the lower the glucose lowering effects. So someone like Mr. W, who has an eGFR of 36, you may not actually get that much glucose lowering from that, but you will still get those benefits on cardiovascular and renal disease, which are probably more important. And when I say ideally should be on Jardiance, obviously not all patients are suitable. And I think we're always about minimizing our effects, so appropriate patient selection. So I would not be choosing for Jardiance. I would not be choosing someone on a keto diet because of the risk of DKA. And alongside that was someone with significant alcohol intake. Those with, frequent UTIs, particularly thrush infections or fungal infections. I'd also be very cautious thinking about steering clear, because Jardiance is going to make it worse. And when you start in Jardiance, you're talking about the importance of genital hygiene. You're talking about the importance of sick day management, which includes stopping the Jardiance or Jardiamet if you're prescribing that whenever they're unwell, and not restarting it until they're well again. And you also, in those with tight glycemic control or tightish, class anyone with an HbA1c less than 64, if they're on insulin sulfonylureas, you're reducing the dose to prevent hypoglycemia. And the rough ballpark figures are that you're reducing the total daily dose of insulin by about 20%, and you're at least halving the dose of sulfonylureas. And you're also thinking about, for those on diuretics, and that includes Mr. W on his furosemide, if not overloaded, you also think about reducing the dose of loop diuretics, just because, empagliflozin itself leads to diuresis. If they're overloaded, you don't need to change anything. It's really those that are dry or well controlled. When you start Jardiance, you will find that most people's EGFR will decrease by up to 25%. That is completely normal. It bounces back over the upcoming weeks to months, but that may explain why. If you see that decline in renal function, it's very similar to when you start an ACE inhibitor or angiotensin receptor blocker. And as I said before, the only time you just stop Jardiance now is if it's not tolerated, or it may be because they're temporarily unwell, or if they're starting dialysis. So if the EGFR drops down to 10, drops down to 15, it's fine to keep going. We now know that it's safe. So for Mr. W, the first thing you do is you reduce his total daily dose of metformin down to 1 gram, but you start empagliflozin given his renal disease and heart failure, and you use that in combination with as Jardia Met, and you reduce his dose of vildagliptin down to the maximum dose for his renal function. Then to prevent hypoglycemia, since he's only on low dose glycoside, you stop that and you reduce that Lantus down from 25 to 20 units, so roughly about that 20% reduction. You've also reduced his furosemide down to 40 milligrams daily, and talk about the importance. Here's someone that you will want to keep a close eye in terms of monitoring their glucose levels and fluid balance just to keep them safe. And it may be someone that you have a phone call in 1 to 2 weeks rather than just waiting to the 3-month follow-up. But you do see him again in 3 months, and his repeat HbA1c is still 58 millimole per mole. So the question is, what am I going to do now? And I'm going to stick to just glycemic control to start off with. And the answer to that is if you ever have someone on Jardiance, typically the next best agent in terms of for glucose lowering is either Trulicity or Victoza. Because that leads to additional reductions in reducing cardiovascular disease, the potent synergizers in terms of reducing glucose levels and weight. And we're starting to also get more data that GLP-1 receptor agonists, which is the family they belong to, are effective at least reducing the progression of renal disease as well. Now, the situation that we find ourselves in, which you'll be very familiar with, is that only one will be funded under special authority. Everywhere else in the world, you can use both together, but we're stuck in this position in Aotearoa. Now, the cheapest way to do that for patients, and I think it's always important to have that discussion with the whānau, is to fund the either Trulicity or Victoza, and then talk about self-funding the Jardiance. Now, it works out about $85 a month, which is understandably outside a lot of people's financial capabilities. But there are options in terms of making it cheaper. One, you could give half a 25 milligram tablet of Jardiance a day, or 1 tablet of metformin with a 12.5 milligram component of empagliflozin and Jardia Met. And that will reduce the cost down to $42 a month, which for some people can be a lot more achievable. And what has been great is that WINS has come to the party for many who are receiving financial assistance already, and they will help fund the Jardiance up on top of the for the patient, and they're receiving the funded GLP-1 receptor agonist under the special authority. And that's one way you can get dual therapy. I think what's really exciting about these new medications, or even though they've been here for a couple of years and the rest of the world for at least 10, is that we can now, many of our patients which were on insulin, we can now get them off insulin. So if you have someone that has an HbA1c close to target, if they're on less than 40 units of insulin a day, introducing Victoza or Trulicity, you may actually have a chance to get them off insulin. It's not necessarily true in those with very progressed type 2 diabetes because they've lost a lot of their beta cells, but definitely those in early disease, there's a chance to get them off. And for Jardiance, I'd probably say it's lower at about less than 15 to 20 units a day, but there's still a chance to get them off insulin, which I think is great. You reduce their risk of weight gain, you reduce their risk of hypoglycemia, so it should be a major goal of treatment. And just as a reminder, if you ever start Victoza or Trulicity, you're stopping the vildagliptin or Galvus because it's become redundant. And basically, you've superseded it. Vildagliptin can still cause adverse effects, so that's the time when you stop vildagliptin because it's no longer needed. And we're in, I guess, a current shortage of Trulicity, and I'll talk more about that towards the end of the webinar as well, in terms of what to do and how to switch people over and what the future looks like there. But you start Victoza 0.6 milligrams a day, and you appropriately stop as Lantus, just to prevent that risk of hypoglycemia. You stop the vildagliptins that's becoming redundant, and you increase up to the maximum dose of liraglutide, which is 1.8 milligrams a day. And he does really well. He's now off insulin, he's off sulfonylureas, so you've taken away any risk of hypoglycemia and weight gain from treatment, and his HbA1c is to target at 49 millimole per mole. And I really want to stress that although 58 is pretty good as an HbA1c, always striving. There's a reason why we have targets. It's to reduce the progression of complications, the development of complications. But now we've dealt with the glycemic control, and obviously it's only a very small part of the overall patient's treatment. So now I want to think about, what do we do about the blood pressure? And just as a reminder, here is his current blood pressure is 145/85 millimeters of mercury. He ensures adherence to all his treatment. He's on a number of medications which will lower his blood pressure, include all those listed there: perindopril, felodipine, doxazine, furosemide, and metoprolol. And really want to think about, we have glycemic targets, also think about blood pressure targets. So if anyone has a burden of complications, ideally the target blood pressure is a systolic less than 130 and a diastolic less than 80. And the caveat to that is obviously we don't want to cause hypotension and cause, we don't want people falling over. I really think a standing blood pressure in the practice is something we probably don't do enough, just making sure that it's not too low. It's fine if it's sitting and standing or lying and standing, as long as we're measuring it, checking for symptoms of postural hypotension. And I'd like to remind you, if we go back to all the original studies for diabetes, particularly the UK PDS, which many of you will be familiar with, tight blood pressure control was actually just as important, if not more important, in reducing all the microvascular, macrovascular complications of diabetes than glycemic control. So even though you may not be winning with the glycemic control at all, if you're winning with the blood pressure control, you're making a major difference. Now, but the significant difference to remember between blood pressure and glycemic control is there's no metabolic memory for blood pressure control. What I mean by that is, for glycemic control, if you're able to, control someone's glucose levels for a period of time, that will have lasting benefits for the rest of their life. And so what that means is, often when, with advancing age, with a greater burden of complications, or perhaps no complications at all, you can actually relax the glycemic control. Now, with blood pressure, that's not true. There's no long-lasting legacy effect or metabolic memory for blood pressure control. That is why you actually need to keep going with blood pressure management. Basically, as the patient ages, you're not cutting back really right to the end, just because, that's just the time to keep getting the benefit from that. Now, the choice of which agent you use to lower blood pressure is typically very driven by the comorbidities and which antihypertensive can kill two birds with one stone, so to speak. So, and a real simple way to consider this is, does my patient have diabetic renal disease or do they not? Because if they have renal disease, what you're going to do is you're going to start an ACE inhibitor or angiotensin receptor blocker, and you're going to increase that up to the maximal tolerated dose. Now, if your blood pressure is still above 130/80 at that stage, that is when you either add a calcium channel blocker or a thiazide, and that's your second and third line agents. And if you've got really refractory hypertension, that's when you think about your aldosterone receptor antagonists, and that's either with spironolactone or plenarone if they meet the special authority criteria. Now, that is how you'd approach someone with renal disease. Now, if you've got someone without renal disease, also I'll cover that actually later in the webinar. Now, I also want to think, most of our patients just don't have one problem. What are the best antihypertensives in heart failure? And once again, ACE inhibitors and ARBs are very important. We know that beta blockers are important. Our ARBs in combinations with neprilysin inhibitors, such as Entresto, are important, and spironolactone. And all of a sudden, you can start seeing where are these commonalities in our patients that have renal disease and heart failure and perhaps other conditions. So I've got here in gout. Now, both losartan and calcium channel blockers have been shown to be effective in reducing uric acid levels. So that may be something that pushes you more towards using those agents in gout. And just be aware that thiazide diuretics may exacerbate gout just for reduced uric acid excretion, which may also be beneficial for renal calculi, but may make gout worse. And then we've got our ischemic heart disease. And this is where we know that, it's beta blockers pretty much first line, and diltiazem may well have a role if intolerant to beta blockade. And that's really where I guess, when you're thinking about what are the comorbidities, these are the medications which are going to convey survival benefits and improve quality of life. And on that, I want you to think about which agent you're going to use in each class. And these aren't necessarily 100% rules. Typically, I will use chlorthalidone as a thiazide, so it's got a much longer duration of action than hydrochlorothiazide. Even though hydrochlorothiazide can be very useful as it comes in combination with the other tablets, which, in terms of reducing the number of pills, aiding adherence, that may be a choice. On that line, half-life is really important. Losartan has a much longer half-life than candesartan, and that may push you towards, using that in a class. Also has the benefit that lowers uric acid levels. In terms of calcium channel blockers, one of my pet hates, I must admit, is seeing, pedal edema due to calcium channel blockers, which would then have a whole lot of frusemide chucked at it. And it's really just due to the calcium channel blockers alone. I tend to use amlodipine much more than felodipine, just because amlodipine is a lot more cleaner and does seem to be, or is associated with less adverse effects in clinical trials as well. Many of our men, in particular, on alpha blockers for their prostatic disease, which is obviously important there. Just be aware that alpha blockers and beta blockers and diabetes alone do not convey any survival benefit. So they're typically our last line agents in managing hypertension, but you may also obviously be using them earlier, particularly beta blockers if they've got ischemic heart disease and heart failure. I do still see some people stopping beta blockers in peripheral vascular disease because they're worried about spasm-reduced peripheral supply. You don't need to do that. Beta blockers are completely safe in peripheral vascular disease, just so you're aware of that. Also, in this situation where there's actually no evidence that frusemide improves survival in heart failure, obviously it does in someone that's in acute heart failure, but really, what our aim is in heart failure is really increasing up our ACE inhibitor or ARB or Entresto. Don't use the two together in terms of just because the risk of angioedema, and your beta blockade to try and get patients off frusemide. Now, Jardiance is also going to be a very important pillar of treatment in non-diabetic heart failure. We're actually expecting already this year for that to be approved or funded for that purpose. It's not funded at present, but just be aware that it won't be long before you'll also be using Jardiance in non-diabetic heart failure. The good news with people without diabetes is that there's no risk of DKA, with Jardiance without diabetes, so you don't need to have that fear in that patient group. We're going to go back now to Mr. W, and because he had the renal disease. You stop his doxycycline. He didn't actually have any significant prostatic disease. It was mainly due to the frusemide, which was making him pee. You stop his felodipine, and you switch his losartan because of his gout, and you're basically trying to maximize that dose, the maximum dose losartan. His repeat blood pressure has improved, but it's still above target. And given that you're trying to get him off his frusemide, you increase his metoprolol up to 95 milligrams a day. And the good news is you're able to control his heart failure that way and keep his blood pressure to target. And I mean, these are all dynamic situations. Each case is different, but here's just showing one approach. How can I maximize the management of his hypertension, his renal impairment, and his heart failure? And now we're going to switch tack in terms of his dyslipidemia. Because just remember, we're always trying to reduce cardiovascular risk whenever we're approaching anyone with diabetes. So to go back and to remind you about his dyslipidemia, so his LDL cholesterol was 3.5, so it should be millimole per litre. Our current dose of simvastatin of 40 milligrams daily, and he was intolerant of higher doses of simvastatin. And anyone that has basically any microvascular or macrovascular complications of diabetes, I basically want you to be thinking about statin therapy unless there's any contraindication. And the main reason for that is that statins will delay the progression of all diabetic complications. In fact, they will often also potentially reverse, carotid intermittent thickness and potentially, macrovascular disease. And another common fear that I see out there is that people think, oh, I'm not going to use statins in someone that's got diabetes or pre-diabetes, because I've heard the evidence that statins make diabetes worse. To be honest, it's only about 1 in 100 patients at most, and the benefits of statins far outweigh the cons. So I don't want you to hold back from that point of view. Our primary target, or LDL concentration, is less than 1.4 millimole per litre. Our secondary targets, I'll be honest, that most of it's around the LDL, but you're also thinking about, can I get their triglycerides down to less than 1.8 and their HDL above 1.2 in women and 1 in men. I typically don't use simvastatin at all anymore in people with diabetes. And that's really just because of the short half-life. It's a lot less effective than its cousins. And I think we've now, rosuvastatin has been a major new option in terms of getting our people with diabetes to a target in terms of their lipid control. Don't forget ezetimibe as well. Both are under special authority criteria. The good news is that many of our patients with diabetes will meet that criteria, particularly either due to ethnicity. For all Māori and Pacific above target, they meet automatically, or by default through their high cardiovascular risk for others. If you're not aware, all statins actually lower uric acid levels, but rosuvastatin is a lot more effective at doing so than the other statins. So you switch his... So I'll just go back just quickly. For patients switching over from atorvastatin and simvastatin, I will say anecdotally in my practice, for those that were intolerant of other statins, roughly at least half have tolerated rosuvastatin absolutely fine. Remember, those that have adverse effects on statins, often the chance of the adverse effects recurring on retrial is only about 50% anyhow. So unless it was, severe, like rhabdomyolysis, I'll obviously steer clear of statins in that situation. But otherwise, I would challenge you to retrial the statin, particularly a new one, or potentially, or also at lower dose. But many of your people with diabetes will tolerate rosuvastatin well. If you have someone that's intolerant of, simvastatin, atorvastatin, rosuvastatin, I'd still be keen to trial them on pravastatin, because any reduction of LDL is beneficial, and pravastatin is typically your best tolerated statin in that situation. But I'd typically always start off at atorvastatin first. You've got rosuvastatin in reserve, and then pravastatin, for those that can't tolerate. But I'm going to go back to, for Mr. W, and you do switch him from simvastatin to rosuvastatin 10 milligrams daily. He tolerates it well, and I think that's really, really important. You see that reduction in his LDL. Remember, you're aiming for less than 1.4 if possible, particularly given his extensive cardiovascular disease background. And you basically increase his rosuvastatin up and get his LDL to target. And then thinking, what else, at his first appointment could you identify in terms of reducing his cardiovascular risk? So once again, I remind you about, what else, is other comorbidities. We're focused on the glycemic control, blood pressure and lipids, but also remembering that he's got atrial fibrillation, he's got sleep apnea. What else out there is can we look at? So one thing I will say, sleep is really important in diabetes management, full stop, and that for obesity. Without decent sleep, often you'll ever struggle to manage blood pressure, appetite, or glucose levels. And CPAP alone, without doing anything else, can be effective at improving basically all your metabolic parameters and reducing your cardiovascular disease. Just thinking about, is he using that effectively? Are the pressures correct? We're obviously never forgetting about smoking cessation. It remains as important as ever. I will say, though, that, just because someone's smoking, don't not change anything else. Reducing blood pressure, statins are still effective in reducing cardiovascular risk in people that are smoking. Remember, statins are actually more effective in people with diabetes than without diabetes at reducing cardiovascular risk. Also remembering alcohol and the other risk factors. Be aware that diabetes increases your risk of thrombotic events with atrial fibrillation. That's why it's, for example, it's part of the CHADS-2 score. And what's interesting in those with diabetes is that your direct oral anticoagulants, your dabigatran, rivaroxaban, appear to be more effective than warfarin. And its mechanisms are not just through anticoagulant alone, but also reducing that microvascular burden. One thing which is always important with people with diabetes is checking their mental health. Depression is much more common in people with diabetes without. There's a whole burden of diabetes distress. Suicide, patients with diabetes are twice more likely to attempt suicide than people without diabetes. There's another sort of little point to remember. About 80% of those that take an accidental overdose of their glucose-lowering therapies, particularly insulin, it's actually intentional. So please be strongly aware that may be asking for help and that it's not accidental. What's also important to know about depression is that it independently accelerates cardiovascular disease. It often also inhibits adherence and treatment. And actually treating the depression alone, that will let you start winning with all the other cardiovascular risk factors. It independently reduces the progression of cardiovascular disease. So treating depression also remains as important as ever. And I've chucked on sexual dysfunction there. It's just as important in men and women. I think it's a lot easier to tell men about sexual dysfunction. We probably don't ask enough in women, but it's also important. And it's really part of quality of life. And I find that many people sex is actually the main thing they want to improve. And that can be the buy-in and improving all the other metabolic parameters and improving that side of function. And it's always important to think about and to ask. So for Mr. W, we'll go back. So for his atrial fibrillation, you start dabigatran, and because of his stable ischemic heart disease, you stop aspirin because of increased risk of bleeding. I'll talk more about aspirin as we go along. And some with stable ischemic heart disease, I've no fear about using phosphodiesterase inhibitors, but obviously you discuss an interaction with nitrates in terms of, you don't want GTN spray on board here. But here you also know that with all the other changes that you've made, that as uric acid is greatly improved, so it actually reduces the allopurinol to a more appropriate dose for his renal function. You're also thinking about the other medications which reduce cardiovascular risk, such as pioglitazone, which I think is a general underuse in this country, but that's contraindicated in some with either edema, including heart failure or osteoporosis. So you would definitely not be using it here, but it's just one of those things that crosses your mind. So here's our overall changes in terms of what we've done over this journey. You can see that we've actually, on the left is his old regimen, on the right is his new regimen. We have basically reduced his number of medications, but we've maximized his medications in terms of for survival benefit, particularly around his diabetes, his cardiovascular disease, his renal disease, and his heart failure. We also reduced his thrombotic risk. We have removed that risk of hypoglycemia and weight gain by taking off the Lantus and sulfonylureas. And we've also got, sildenafil there, which is purely around quality of life. And so that's what our focus has been for Mr. W. And just trying to think about, when you break it down into each area, what am I going to do to maximize his management there? This talk is about diabetes, so we'll get back to it. But just remember those glucose-lowering therapies, which independently have benefits up and above that of glycemic control. So for those, for reducing cardiovascular disease, there is your metformin, Jardiance, Victoza, Trulicity, and pioglitazone. So they are the ones in your patients with cardiovascular disease that you're thinking about secondary prevention. They're the agents to think about. Jardiance will also reduce renal death and heart failure death and slow the progression of those diseases. So think about that there. We've also got glucose-lowering therapies which aid weight loss, and it's only about 1.5 to 2 kilograms maximum for metformin, but we know for Jardiance and our GLP-1 receptor agonists, that can be a lot more, can be very potent. And the only glucose-lowering therapies which will cause weight gain and hypoglycemia, and particularly hypoglycemia, are insulin and sulfonylureas. None of the agents will cause hypoglycemia. So another one, I'll be honest, another one of my pet hates is people that are told to eat when they have diabetes to prevent hypoglycemia. They're munching on jelly beans when they're just on the other agents alone. They do not need to do that. They will not have significant hypoglycemia. It is only patients on insulin sulfonylureas. So please remember that. Pioglitazone will not cause hypoglycemia, but often it leads to about 2 kilograms of fluid retention, which some patients understandably don't like. So that's when you think about the other benefits or adverse effects of glucose lowering therapies. For vildagliptin and acarbose, they're sort of weight neutral, cardiovascular disease neutral, so they don't provide any additional benefits, which is why they've sort of gone down the ladder of glucose lowering therapies. As time goes by, Mr. W now presents with worsening neuropathic pain of his left foot. He is taking some ibuprofen and codeine, but he's having difficulty sleeping at night. Around his old amputation site, he's now starting to get infection. You gave him some flu clocks. It did get better, but now it's starting to get worse. There are no signs of acute ischemia. So the question is, how will you manage his pain and infection? First of all, I think we're just not assuming anything's all just due to diabetic neuropathy. You want to exclude other causes. You know, you're doing his thyroid function, you're doing a vitamin B12 level, given he's on metformin. You don't need to necessarily monitor vitamin B12 regularly on metformin, but definitely someone with symptoms of B12 deficiency would be, and that's definitely what you do here. I think another important take-home message is you don't want these patients on non-steroidals. You might well kill them or knock off what renal function they have. And opiates also aren't typically effective for diabetic neuropathic pain. So you're then thinking about, well, what options do I have that are safe? Topical capsaicin cream can be actually very effective for localized pain, but make sure you don't apply it to broken skin, and make sure you talk about correct administration. And that really is around just making sure it's localized to the site. Patients are washing their hands well afterwards. They're not getting it anywhere else because they will know about it. It will burn. And getting people to know that it will take at least a week before you start to see any benefit, probably at least 4 to 6 weeks before you start seeing the full benefits. And it will burn initially, but that burning sensation will typically go away after a week or so as well. So it's not an automatic thing, but for very localized pain, it can be quite effective. Otherwise, for more systemic pain, you're then looking at your analgesic ladder. It's not forgetting about paracetamol. It is still have a role. Then you're going into your tricyclics, and I typically use low-dose nortriptyline. It's a lot cleaner in terms of more effective and less adverse effects than amitriptyline. You're typically looking at 10 to 20 milligram doses there. Then it's pregabalin is the next cab off the rank. There's actually very little evidence supporting gabapentin being effective in diabetic neuropathic pain. There is for pregabalin, so that's why pregabalin's next. And then if you've got really refractory pain, carbamazepine has been shown to be effective there. And that's the approach that I'll take for neuropathic pain. Remembering in diabetes, you're treating any bacterial and fungal infections early, and often you will need a prolonged course. Often 1 week is not enough. And you're also thinking about wider coverage than just necessarily your gram positives. So do think about swabs and culturing. Sometimes you may need to, for example, go to Augmentin early for 2 weeks to try and get on top of it. And then think about when do you refer. The great news, it's the same in every region across the Motu. So, you should be familiar with this, hopefully. But if you have anyone with ulceration, particularly if they've got any ischemia or gangrene or spreading infection, or possibly if you think about a Charcot foot, so it's a hot, swollen, deformed joint, particularly if there's an absence of trauma, they need to be seen acutely. And otherwise, you're thinking about community podiatry input. I know that varies a lot from region to region, but is very important in preventative care. These are any of the criteria. Basically, anyone that's ever had active foot disease can be seen for follow-up, and any two of the following. It can be any two of these. So just remember, all those with significant renal disease and Māori ethnicity, for example, will qualify to be seen. And just really want you to remember about accessing podiatry care. So that was Mr. W. We're actually going to shift tack now to Miss C, and I will take questions at the end. Please keep them coming through. And we're going to change tack now, as I wanted to make sure we covered young people with diabetes, as they're a very important group as well. But this is a 17-year-old Samoan woman with type 2 diabetes, recently diagnosed, current weight 120 kilograms with a BMI close to 40. She's not doing too bad with an HbA1c of 57 millimole per mole on 1 gram twice a day of metformin. I want you to think about what are the next best glucose-lowering therapies here to escalate therapy. Once again, this is not an uncommon situation that we're encountering every day and in practice. So I know we've been thinking about pharmacotherapy up to now. I really want to stress the importance of lifestyle intervention always being important in managing diabetes, and particularly in early disease, we're thinking about can we achieve remission? And that's where a very low-calorie diets, direct style intervention may well play a role. And also think about our targets for weight loss. So 5% body weight loss will lead to a significant improvement in metabolic parameters. To get remission of diabetes, it appears that sort of 10 to 15% of sustained body weight loss is seems to be the magic number. So you're looking at at least 12 kilograms of weight loss here, but it's important that you're not talking about her getting down to 70 kilograms. This 12 kilograms of weight loss may well be a pragmatic and achievable target. Beware in young people with diabetes that vildagliptins and other DPP-4 inhibitors have shown to have no benefit in this group. And this is the one group where we are worried about sulfonylureas progressing beta cell failure. It's still not necessarily conclusive, but we wouldn't typically use these agents in this group. But what we do know is it's great that all the new agents, such as Jardiance, Victoza, Trulicity, are safe and effective from the age of 10 years. And more than that, basically, we've just spoken about it. Jardiance and the GLP-1 receptor agonists can be great at aiding weight loss. And I sort of spoke about before, sometimes it's very difficult to choose between the two, and often patient preference will be the biggest factor that drives you there. There's no real head-to-head studies showing that any agent is superior, but I want you to think about, what other factors which may sway me more one way towards the other. If anyone's got renal disease or heart failure, that should push you towards Jardiance. Saying that, if you've got someone that has cerebrovascular disease, well, there's actually no real benefit or no real evidence for Jardiance, that may push you towards a GLP-1 receptor agonist. If they've got contraindications to Jardiance or they can't tolerate it, that will push you towards a GLP-1 receptor agonist. There are many people that don't like taking tablets. There are also many people that don't like taking injections. That may push you one way. You probably get more weight loss with GLP-1 receptor agonists than you do with Jardiance. So that may also push you one way. At the same time, you may have a patient with gout, or they're self-funding their medication, and Jardiance is cheaper and it may push you that way. But remember, patient preference may drive it, but it comes to all these factors when you're considering which agent do I choose. So for Miss C, as we go through, her blood pressure is 127/80 millimeters of mercury. Normal photo screening, no evidence of neuropathy at all, no evidence of renal disease, and the LDL is 2.5 millimole per litre. You put her numbers into the predict calculator, and her 5-year risk comes out at 1%. And the question is, should she be started on ACE inhibitor, ARB, statin, and aspirin? Because to be honest, this is pretty much what we did 10 to 15 years ago. Everyone with diabetes went on to these agents, but things have changed. So, but I will say the first thing is for blood pressure in youth with diabetes, ideally would be aiming for a tighter target of less than 125/80 millimeters of mercury. Would actually also be aiming for a tighter HbA1c of less than 48 millimole per mole. Obviously, we don't want to cause hypoglycemia, but the reason why we're aiming for more aggressive control is they have a lifetime burden of disease. It's a lot more aggressive disease than what it is in adults. Now, what we know now is that ACE inhibitors or angiotensin receptor blockers do not prevent renal disease. Okay, so they are very good at slowing down the progression once it's there, but they do not prevent. So if you've got someone with diabetes and hypertension, if they've got no renal disease, it's absolutely fine to use an ACE inhibitor arm, calcium channel blocker, or thiazide, because other agents have all been equally shown to improve survival. Other agents such as beta blockers, They actually haven't been shown to improve survival, and they may be associated with adverse effects such as sexual dysfunction and weight gain. So I always steer clear of it if possible. We now also don't typically use aspirin at all for primary prevention of cardiovascular disease in people with diabetes. The reason why is aspirin doesn't work as well in people with diabetes, and it actually makes people bleed more in people with diabetes than without. Unless you've got someone that's extremely high risk for cardiovascular disease in terms of primary prevention, I will not be using aspirin. In fact, what I find myself doing is stopping aspirin more often than starting in these people. Another take-home message is that all cardiovascular risk calculators significantly underestimate risk in young people. For example, even though her 5-year risk of a CV event is 1%, her risk of dying from MI at 40, maybe 50%, which is obviously still far too early. And it's really about thinking, about the pros and cons of treatment. I still think it's a really hard decision. When do I start treatment? It's very easy once you've got complications. I think those without complications, it's largely driven by patient preference, but I think it's important to talk to people with diabetes about if they want to do all that they can about starting, lipid-lowering therapy and antihypertensives early, if possible. So what you do for Miss C is that you do, she prefers Jardiance, just being a tablet. So you increase the metformin up to Jardia Met, and her repeat HbA1c in 6 months actually increased to 62 millimole per mole. She's also got some oligomenorrhea, only having, roughly about 4 or 5 periods a year. She's got the persistently deranged liver function tests. And once again, this is very common in your people with diabetes. You can see she's got a raised GGT, ALT, and AST are roughly that 1.5 to 1 ratio between ALT and AST, which is very typical of fatty liver or metabolic liver disease. Alongside that, ultrasound does reveal extensive fatty infiltration and polycystic ovaries, which are also very common in women with diabetes of this age. And the question is now, how will you escalate her glucose-lowering therapies? And I do want to remember as well, type 2 diabetes is a progressive disease, and it's through no fault of the patient. If we could stop the death of beta cells, we'll get a Nobel Prize. But just don't assume that people aren't taking their medications, and particularly in young people, it is a much more aggressive disease than what it is in adults. And you will see this even though she's taking medication, the HbA1c may rise. And we do have glucose-lowering therapies which do have independent benefits on reducing liver fatty deposits, and pioglitazone in particular is beneficial here. But our GLP-1 receptor agonists and Jardiance are also very useful. Once again, the latter two are also useful in reducing weight. And another thing which I often see forgotten is that polycystic ovarian syndrome is a diagnosis of exclusion, and that polycystic ovarian syndrome itself is a misnomer. And what I mean by that is that you can have polycystic ovaries on ultrasound, and you do not have polycystic ovarian syndrome. And similarly, you can have polycystic ovarian syndrome without having polycystic ovaries. And I think it's not a great name. But I want you to think about at least once, what are the other potential mimics here? Could this be Cushing's? Are androgens very high, and potentially could be androgen producing tumor or other causes? And that's what I think whenever you see polycystic ovaries, I think it's useful that you at least measure her androgens and a 24-hour urinary cortisol, potentially 7-hydroxyprogesterone as well, just making sure that you have excluded things, if it does seem atypical, and particularly if it's, really fast progressing. But for her, remember that if you have an HbA1c above target, you can increase the dose of Jardiance up to 25 milligrams a day. And you can use basically SGL2 and GLP-1 receptor agonists together. They're very good together. And so you add in Trulicity. The pharmacy cannot source it, so you switch to liraglutide at 0.6 milligrams a day and up titrate to 1.8 milligrams daily. I'll talk more about that on the next slide. She's doing well from the glycemic control point of view, but then she has an exacerbation of asthma. So you start prednisone 40 milligrams daily for a week. Her glucose levels are now greater than 20 millimole per litre as expected. And the question is, how will you manage a steroid-induced hypoglycemia? This is not just true in Miss C, this is true in all your people with diabetes. I will go through with Trulicity. Unfortunately, there is supposed to be another shipment filtering down to pharmacies this week. But I think realistically, we may struggle with supply to at least the end of the year, and it's due to a number of factors. It's just not worldwide demand. There's complex supply chain issues. And so we are going to be forced, particularly for those starting GLP-1 receptor agonists and those that can't source at the moment, switching from Trulicity to Victoza. You do need to do another special authority. We're trying to change that with Pharmac, so it's only one special authority, so I don't need to do that. And make sure you prescribe the needles with Victoza. You don't have to for Trulicity, but you do for Victoza. I'd start, for those that you're switching over, I'd start on 0.6 milligrams a day, and I think it's fine to ramp up by 0.6 milligrams every couple of days if they're tolerating it well to that 1.8 milligram dose. If they're naive to, they haven't been on Trulicity before, I'll probably go on 0.6 milligrams a day for a week, then 1.2 milligrams a day, then 1.8 milligrams daily. If you ever have someone that has steroid-induced hypoglycemia, sulfonylureas and insulin are actually first-line management of that hypoglycemia. That's because steroids reduce insulin secretion. So in someone that's insulin naive, I would actually think about starting weight-based insulin. If you've got someone that's already on insulin and you're starting high-dose steroids, I'd say anything over 20 milligrams a day of prednisone or 0.5 to 1 milligram a day of dexamethasone, you look at needing to increase your dose of insulin by about 30%. Just whilst on the steroids. Remember to reduce it back down when they're off their steroids. But Miss C goes away for a few years and she returns to your practice. Unfortunately, she had a miscarriage following an unplanned pregnancy, but she is keen to get pregnant again. Her HbA1c is currently 84 millimole per mole. You can see that her medications there, including she's on atorvastatin and perindopril. And the question is now, how will you optimize care for a pregnancy? So the first thing I'll say here is please remember contraception in all your women with diabetes of reproductive age. Diabetes does make pregnancy high risk. More than that, if you start treatment, particularly metformin and either Victoza or Trulicity, they increase ovulation independently of the reduction of glucose levels. So be aware that you actually may start ovulation, and all of a sudden people that weren't on contraception get pregnant. Weight loss and improvement in glycemic control will also lead to ovulation. So please be aware of contraception. Ideally, because diabetic pregnancies are high risk, they would be planned. And we're aiming for that target less than 48 millimole per mole if we can. Sometimes I will be biased being male, but I often think we forget about the importance of glycemic control in men with diabetes who are potential fathers. If they have suboptimal glycemic control, it does affect sperm motility and quality. It's an important part of fertility as well. So we should be thinking about improving their glycemic control as well. If we stick to women now, if you're looking at aiming for ideally preconceptive care, and I will say 80% of pregnancies aren't planned, but in the 20% that are, if you can get the HbA1c less than 48 millimole per mole, that's great. Obviously, individualizing it. If they are on insulin or sulfonylureas, you're starting the high-dose folic acid and iodine. You're stopping any teratogenic medications. Now, statins definitely fall in this group. ACE inhibitors and ARBs actually only become teratogenic in the second or late second, third trimesters. So if you've got a woman with significant renal disease, I'll be actually tempted to keep them on the ACE inhibitor ARB in the first trimester. And that is something you obviously be discussing with the obstetric team, midwife, etc. And you may also consider switching to glucose-lowering therapies, which are safe in pregnancy. And at present, we only have metformin and insulin. We don't, the others aren't safe. We don't particularly have safety data during pregnancy. So you may decide to think of that. You may actually decide to stay on their original regimen if that's more suitable to the patient and the situation. It's hard to have a blanket rule here, and it's very patient specific. So that was a very whirlwind trip through diabetes and many of the comorbidities. I hope you learned a lot through that. I know that the management appears complex, but I think it does help breaking it down into separate areas. What can I do in each comorbidity to maximize management, to increase life expectancy, improve quality of life? What are the best medications to minimize adverse effects and the number of medications? I always preach about trying to reduce clinical inertia at every time, but I know that another point I haven't discussed at all is that often you don't have the time in one appointment to to do everything. It may only be one thing. It's about, it's not necessarily the speed, but making sure you get their way along the journey. It may take multiple appointments. I'd encourage you to use all the other members of the multidisciplinary team, your nurses, your pharmacists, you may have kaiwhina, kaimanaki, dietitians, secondary care, podiatrists, anyone else that can help, psychologists, just because it is overall wraparound care to help. And, it can be overwhelming in one appointment. But basically, happy to take any questions. I'll fire it over to you, Bruce.
Okay, got lots of questions, sir. So we, I guess the first question was the dose of the NOAC there was 150.
Yeah.
I think we generally use 110/80, but is it because you because of the age of the patient, or you weren't?
Oh no, to be honest, I would have just chucked a dose down without strongly thinking about it, Bruce. So I would, I would stick to that. To the normal guidance.
No, some great questions there. And I guess the issue is you made the point about Jardiance being good for all types of heart failure with the reduced ejection fraction preserved, or even the middle range stuff. Yeah, so that's good. There were some questions about the WINS benefit. That goes to the patient, not to the pharmaceutical company, doesn't it?
Yeah, it does. And sometimes, we'll go to the patient, it'll be part of the disability allowance. For some things, I will say sometimes I write for the money to go direct to the pharmacy, for example, but I think it's just often easier going straight to the patient.
Okay. Do you need sick day rules for non-diabetics with SGLT2 inhibitors?
No, it doesn't seem to be that risk of DKA in those without diabetes. So it just appears safe to carry on. I think if you had someone that was significantly unwell, you may think about stopping it. To be honest, I haven't had much experience in that group, but definitely those fears that we have over sick day management and people with diabetes aren't borne out in those without diabetes.
And a number of people asked about there are a lot of changes you'd make there. And my feeling's always been if you change more than one medication at a visit, then you don't know where the side effects are coming from. Would you just go for the blood pressure first and then leave the other things? Yeah,
I think it very much depends on your patient. There would be also some patients who may become overwhelmed with multiple changes, and only one change is recommended. I think, though, you can often tease out the adverse effects, from each medication. So, I'm not afraid of starting 3 or 4 medications or doing all changes at once. I've got the benefit also having a 30, 40-minute consultation with a patient, so I can go through it in a lot more detail. But I think, for example, you can, if it's hypotension, you can tease out from the antihypertensive versus, potentially GI adverse effects from the, from the glucose lowering therapy. So if the adverse effects are distinct, I wouldn't be discouraged about doing multiple changes. But if it's going to be too overwhelming for the patient, obviously, you don't want to lose the patient through having multiple adverse effects either.
At what age do sulfonylureas and vildagliptins become effective? This would be for the second.
Yeah, I don't think there's any magic age. That the studies that have been ineffective really been in those under 20 years of age. It's clear that they have benefit in adults. I think you could extrapolate that from the age of 20 years onwards. So I wouldn't have, anyone over that age, I wouldn't have any fears about using them in that age group.
Okay, so question, why is vildagliptin ineffective in young adults? I don't know, you may have covered that.
We don't actually really know, to be honest. It's just that all the RCT data in that group literally shows no benefit in reduction in glycemic control. And you try and think about the physiology involved, and it's hard to necessarily come up with a distinct mechanism why it's not effective. It's just that there's actually no evidence to support its use. Saying that, there's no evidence to say that it causes harm. It's just that just be aware that you may not be doing much and you may need to add in another glucose-lowering therapy.
Your list of meds for neuropathic pain, are you adding on or instead of?
I often add on in terms of using... basically, this is true for glucose lowering therapies as well. Often I see people describe switching or going from one, and all that you do is you're always chasing your tail. And it's actually about adding on. Saying that, with analgesic ladder, you may find that when you're adding on, you may get that combination of adverse effects, particularly drowsiness, for example, the nortriptyline and the pregabalin together. So you may decide to stop one, particularly if it's ineffective. But generally, everything in diabetes is add-on rather than switching. The only times you really stop if you start a GLP-1 receptor agonist, you're stopping vildagliptin. And if you're starting mealtime insulin, you stop sulfonylureas once the mealtime insulin is established. But otherwise, you're adding on.
Question, I don't quite understand it. NZF refers to 2 Trulicity injections being able to be used off-label. Thoughts?
Yep. So with Trulicity, and just so we're, if the HbA1c is above target, we have been recommended you can go to 2 injections a week, and then again still to 3 injections a week. And that's because we do not have the 3 and 4.5 milligram doses available that are overseas. And there's no actual limit in either MedSafe data sheet or New Zealand formulary. I've had a lot of people ask me about whether you can go up higher with Victoza, for example, the 3 milligram a day dose to match that of Saxenda. The one note I will say on that is that both Pharmac and MedSafe are very clear not to go above 1.8 milligrams a day for Victoza, whereas there is no limit for Trulicity.
Can you use rosuvastatin in patients with impaired renal function, eGFR less than 30?
That's a good question. I'd have to double check that myself. You do have to lower the doses in renal function. I think from memory you can still use it, but you are using lower doses.
Use of CBD oil for neuropathic pain with Mr. W. Any comment?
I'm not aware of the necessary specific benefits in diabetic neuropathic pain versus other neuropathic pain. I think it would be a reasonable option if you're not winning anywhere else. But I'll be honest, I'm not aware of any evidence supporting it in diabetic neuropathic pain.
Okay. Any comments on Trulicity for weight loss?
I think it's a really good question, because I'll be honest, I would not be advocating Trulicity for weight loss alone, particularly in our shortage. I'd love it if it was restricted to people with diabetes. It is not registered for, I'll be honest, it's not registered for weight loss in Aotearoa. It's only registered for diabetes, even though I know a lot of it's been used off-label. And the fact that it's cheaper than Saxenda. But ideally, if you did have patients on a GLP-1 for weight loss alone, it'd be great to use Saxenda.
And would you mention using Jardiance as well as Trulicity if you were looking for weight loss?
So for all these medications, when you're escalating the dose, so when you increase the dose of Jardiance, or when you're increasing the dose of Trulicity, your only reason why you're doing it is for glycemic control. So you don't get any extra benefit on reducing cardiovascular disease or renal disease, but you do get the extra reduction in glucose levels. So for example, if someone was on 10 milligrams a day of Jardiance and HbA1c was 48, I wouldn't be increasing it. Even if their BMI was 40, you're primarily basing that increase on glycemic control and not weight. And then if you're thinking about weight loss, I wouldn't be afraid of thinking about our traditional pharmacotherapy for weight loss. And I guess that's the pros and cons of Duramine versus Contrave versus Saxenda.
With that first man, was increasing the dose of Jardiance an option?
Yeah, it definitely was. I can't recall if I did that, but if the HbA1c is above target, then I would be increasing to 25 milligrams a day, and that's not dependent on renal function, or you can do that.
At what age wouldn't you start empagliflozin towards the elderly age? I've started a few older people with preserved ejection fraction.
And that's a really good question, because I know the MedSafe data sheet says caution in using the age over 75. I wouldn't be using age as a pure cutoff. I'd be much more basing it on their frailty. So if you had a very fit and well 80-year-old that would benefit from Jardiance, I'd have no issues using it in that age group with appropriate guidance. Saying that if you had a 60-year-old who had frequent UTIs, fungal infections, that person I may actually be thinking about not using it. I think you're always weighing up the pros and benefits. Saying that all the studies haven't used, typically studied those over the age of 80 years. Similarly, there's not much data on primary prevention using statins for those over the age of 80. There is some data, though, showing that both are effective for secondary prevention. But age, so you're just thinking about, age does come into it, but it's not a pure hard and fast cutoff. Nothing magic happens once you turn 80.
Any advice for a patient taking antipsychotic medication and diabetic medication? Yeah,
I think it's being aggressive with their diabetic medication, just because of the risk of diabetes with antipsychotic medication. It's not just through appetite and weight gain, it's through other mechanisms as well. So just be wary that you may need to escalate therapy, or the actual glucose lowering therapies are fine. I think it's often great using those that will promote weight loss just because, or at least weight neutral, just because the weight gain that you get with antipsychotics.
I thought that candesartan had a true 24-hour cover for BP, and losartan was only 24-hour cover. I
was going to say, I think I actually got it wrong, talking. It's a good point.
Okay.
Yeah, I realised that at the time. But yeah, candesartan does have a better coverage, but losartan does have the benefit of lowering uric acid levels, which hasn't been shown for candesartan.
Is empagliflozin funded for heart failure? Could a type 1 diabetic with heart failure have it?
For those with diabetes, obviously it's funded. I'll be very, very cautious about using it for someone with type 1 diabetes, just because the risk of DKA, and I would not be doing that without going through secondary care in terms of that. I know that there are lots of people without diabetes self-funding Jardiance that have heart failure, but we're really just waiting for Pharmac to fund it. It seems a no-brainer, and that it's one of the major pillars of treatment of heart failure overseas, and it will become here in Aotearoa soon.
That was a great primer on cardiovascular disease. You really touched sort of north, south, east, west on how to manage cardiovascular disease in those cases.
I think it's always important, Bruce, when you, I mean, let's be honest, it's what most of our patients with diabetes die from. So how can we, stop that from happening?
And I also think at the other end of life, the last things you want to stop are the cardiovascular things, because that's what kills people.
It is, and particularly, even in breast cancer and prostate cancer, for example, we know they've got cancer burden, but often these patients are dying from cardiovascular disease, and that cutback in medications is too early. I think you're definitely right there, Bruce.
Question here, wondering why we choose perindopril in the first place. Patients may not tell you they are forgetting doses. I don't know. Potential risk for good adherence.
I don't know. I think once daily medications have a good role in adherence.
Yeah. That's the longest acting one on the market, I think, isn't it?
Yeah, it is. It is in terms of for once daily, because you will find that, for example, Acupril, Quinapril, or enalapril have much shorter half-lives.
Have you seen any worsening of lipid profiles while starting empagliflozin?
I haven't personally. I'm not aware of any. Often, I will say, if you can improve glycemic control itself, you will get an improvement in lipid studies. Theoretically, though, you do get a shift in, from glucose to fatty acid metabolism. So you could argue perhaps you may get a deterioration, but to be honest, I haven't seen it clinically to any significant degree.
And most of these people are going to need statins anyway. I mean, I think it's very difficult with diet to get down to LDLs of what we use.
Oh, it is.
In fact, 1.6.
I mean, at least probably 80% of your LDL is genetic. It's very hard through dietary modification. Not saying that dietary modification is not important. It's also being realistic as well about often you need help to get down to reach targets.
So how long after the use of Trulicity do you see the effects of weight loss and reduction on HbA1c? Yeah,
well, you will start seeing some of the benefits on reducing glucose levels within 2 weeks. Often the HbA1c will follow behind that, always lags by, at least 3 months behind that. The weight loss is ongoing. If you look at the mean weight loss at 2 years, it's, you're looking about sort of 3 kilograms on average. I will say, though, that is very dependent on the lifestyle changes that go along with it. I've seen many patients gain weight on Trulicity. I've seen many others lose 20 to 30 kilograms. So it's really a great time to re-emphasize the importance of lifestyle changes, to get dietitian involvement, etc., and trying to maximize those benefits.
Now, I've got a question here that will be music to your ears. I'm trying to find a comprehensive training course to really get diabetes and understanding prescribing at all stages of renal disease. What would you recommend? Well,
it's a loaded question. It's a great question.
It's not for me. That was the first one we got, bona fide.
For those that aren't aware, I am running an advanced diabetes management course through both University of Waikato and New Zealand Society for Study Diabetes, or NZSSD. It's been great this year. I just had it in the Midlands last year. We had about 300 involved. We're running it nationally this year at 1,100. We had to cap it at that number. We're going to run it every year. Unfortunately, we're all full up this year for those that aren't on it. But if you email me, my email address is ryan.paul@waikatodhb.health.nz.
Oh, and that's great that you're getting such a such a large number, isn't it?
Yeah, no, it's fantastic to see the interest. People are really keen, and what's great is we've now got tools in the armory to make big changes. So I really encourage you to get on board and make a difference for a whānau with diabetes.
So thank you very much, Ryan. You are the superstar of diabetes, I must say.
Yeah, well, thanks, and thanks all, and have a good night.
Okay, thanks very much.